Thank you for joining us today. We just had a wonderful panel talking about how AI is revolutionizing healthcare. And now we're going to pivot a little bit, as you heard, to talk about how AI can be utilized in community settings and to transform public health. And we've got some wonderful panelists here who are going to tell us about some examples, some use cases, if you will, of how AI can truly transform our approach, not just to individual patients or groups of patients, but actually the broader world. How do we use this in communities? How can we actually transform our approaches to public health and improve the health of the population? My name is Donald Lloyd-Jones. I'm a professor of preventive medicine and medicine at Northwestern University here in Chicago. Have the honor of being a past president of the American Heart Association. And I'm joined today by really three wonderful panelists, and I will give brief introductions. And then I'm going to ask each of them to give us about 3 to 5 minutes about their work using AI in community and public health settings. And then we're going to kind of open it up for questions and a free-for-all dialogue that I hope you all will contribute to. I know you will. And we'll also try to draw the audience in for any questions that you all may have as well. So thank you so much for being here for this great panel. And I'll start off by introducing just immediately to my left Aaron Holm, who is the founder and CEO of the Patient Circle Research Institute. Aaron's going to tell you he is actually a survivor. He's a patient who's undergone cardiac surgery and is doing really wonderful work working with patients to do peer coaching and helping them live their best lives after cardiac interventions. To his left, I'm pleased to introduce Cheryl Brown. She is currently a senior program coordinator who does professional certifications for the American Heart Association, but she's going to be sharing some work that she has recently done as part of the Cooper Wellness group located in Dallas as well. And obviously, the Cooper Clinic and its allied businesses have been associated with the space of wellness and thinking about longevity for a long time. So she's going to share with us some of her experiences. And finally, last but not least, Dr. Sabina Gandhi, who is the chief of the section of preventive medicine at Loma Linda University in California, will be sharing some of her work in the Veterans Administration health system and how we can use AI to transform public health in important populations like our veterans. So thank you, all three of you, so much for joining us. And Aaron, maybe I'll turn to you first. If you could share with us a little bit about what Patient Circle does, how you started on that journey of using AI and helping patients through their health journeys after cardiac surgery in particular.
Sure, thank you. Whoa. And thanks for inviting me, and thanks to Pat for inviting me for the panel. I was noticing I don't have any letters after my name, and so I'm a surgery patient. I had a quintuple bypass in 2018 after 25 plus years of pretty advanced heart disease, and I had a difficult experience. So I had heart surgery. Physically, I went through it fine. I found myself with a difficult recovery, and then I had depression for a good 3 or 4 months. But I had excellent coaching through it, and so I was able to come through. And when I came through the other side of depression and I healed and it all cleared, I was just amazed and trying to figure out what had just happened. And so what I came to understand was that the surgery had been a trauma. And that when the trauma had cleared, life looked very different. And then what occurred to me after that is that cardiac surgery is a scheduled trauma. And so if it's a scheduled trauma, then certainly there are things that we can do to get ahead of it. So I was doing some work with the Foundation for Healthcare Quality in the state of Washington, trying to figure out how I could be useful. And they track a lot of data around outcomes. And the idea came to me to train up as a coach. I built a number of businesses over the years, so I have kind of a nutty entrepreneurial mind, and I thought it would be interesting to introduce an idea of peer coaching. So this idea that there's 2 aspects that Patient Circle Research Institute's based on. One is that heart surgery is a scheduled trauma, and that 2, patients can help patients through that process. So I trained up as a coach. I got certified as an ICF developmental coach. And then I introduced an idea to the cardiac surgery team at Swedish. I said, I want to take a group of patients through a peer coaching program and let's measure what it does to their rates of participation in cardiac rehab and to anxiety and depression. And we did a small study, and it was 100% of people went to rehab. Everybody reported great outcomes, and so now we're expanding that study. So Patient Circle Research Institute is essentially studying the effectiveness of peer coaching for cardiac surgery patients so that we can gather data that shows its effectiveness and bring it to a broader set of people. And then also at the same time building community where we're able to connect people with each other on an online platform that we have so that peers can connect with each other, share stories, share resources, et cetera. And the application of AI in that model is essentially we're learning a lot of data that nobody else has. So we're basically having coaching conversations, we're having conversations between patients. This is not data that exists anywhere else, and so we're using it to train a model to figure out how AI can be helpful and supportive to the peer coaches. And so how can AI be a supportive model because it's accessible, an avatar or a peer coaching agent, we call it the patient assistant. So the patient assistant is a resource that's available 24/7. It's available for near zero cost, and it can augment the experience of peer coaching and continue to raise the experience because my experience was you're much more likely to experience depression as a result of heart surgery than you are any significant complications. So, AI as a model, the heart surgery, it's so good. I mean, the care is good. The care of the physical body is so well done, but what's missing is the emotional and mental health aspect, and so that's what we're looking to do from a peer perspective.
Aaron, thanks so much. That's a great description, and you've already generated about 100 questions that I have for you because it's so interesting. Really appreciate that. Cheryl, I'm going to turn to you just for, again, kind of a brief overview of your recent past career, and I know you focused on gait speed and walking speed as an indicator of longevity, healthy longevity, and many other potential health outcomes. How can AI help us in that venue?
Yes, well, again, gait speed is considered the sixth vital sign. It's the only dynamic and complex vital sign. It looks at the walking rhythm, cadence, speed, and step length of individuals in walking. And really, right now, we are resource limited as a skilled physical therapist. For 25 years, my passion has been in treating patients that have cardiovascular disease. And I have my specialty in cardiopulmonary as well. Lots of years working cardiac rehab, treating patients after their heart event. But most recently, I was at the Cooper Clinic. And so our focus there, of course, is prevention and wellness. And so really, when we look at walking speed, it's just an amazing measure. Everybody should be looking at it as a predictor of long-term health. And so many studies have shown that how fast you walk is a direct predictor of your functional ability and the age at which you'll decline or require hospitalization. It's also directly linked to cardiovascular health and cognitive status, as well as all-cause mortality. So really, as a physical therapist, what we do is we assess an individual's walking in a very skilled manner, but there's variability and there's resource limits. So the exciting thing now in living of this time with AI and deep machine learning is that there's a lot of models being developed now which individuals can work on improving their walking speed. And so AI is just doing what we've done for quite some time and offering some great solutions. So I look forward to continuing to talk to you about that.
Thanks so much, Cheryl. Really appreciate that. So Sabina, as I mentioned earlier, you work in the Veterans Administration Healthcare, one of our largest healthcare systems in the country, and obviously a vulnerable but also very important population with a lot of health challenges. How are you using AI in that setting?
Okay, thank you for the introduction. And what I thought I would do is first give everyone kind of an idea on what the scale of the VA really is for those individuals that don't know. So at the VA, the largest integrated healthcare system that we have in the United States, we serve about 9.1 million veterans. Oh, first the disclaimer. At the VA, I have to make sure I say that the views I'm presenting today are my own. They don't necessarily represent VHA or their components. But for those individuals that don't know, With 9.1 million veterans that are being served in our facilities, that's about 170 VA medical centers across the country. There's also about 1,200 outpatient sites of various complexity. Now, we also take care of their family members and their spouses. So from the AI perspective, you can imagine it's a centralized system in which we have a large data bank in which we have a tremendous capacity for research and looking into metrics of this very vulnerable but widespread population. Demographics are very different. Health literacy is very different. The geographical location that we heard Dr. Ali mention. So we have this capacity to really look at this large scale of individuals. Now, what I would like to do is kind of share how things work at the VA and hope that that can kind of transpire or transform into some inspiration about what we could do in the community. So from the AI perspective, just one more bit on that is we have applications in research in virtual reality. We are looking at how we can treat individuals. We do a lot of research that's practical, but also integrating machine learning and using those applications. Now, what I'm hoping to share with all of you is that the care model that we have at the VA and how can we actually transform this into changing public health and community care. So when an individual registers at the VA, they are assigned a patient-aligned care team, or PACT. And that patient-aligned care team involves a primary care provider, a social worker, a registered dietitian. It will have a nurse care manager. If they're tied to mental health services, a mental health provider as well. The patient is the center with all of us supporting that patient. So in any given moment, I can reach out to one of their team members for a patient that is in need of a service. So let's just take, for example, I have a patient, Mr. Jones, not to be confused with Dr. Lloyd Jones here, but Mr. Jones, right? So he's talking to me, I'm addressing his tobacco treatment, but he tells me, I need to go to an ER, I don't, and this is a real case, but I don't have the means, I only have $40 in my pocket. I can't afford Uber, and I'm 65 miles away from the VA. So in that given moment, I can reach out to his social worker, his nurse care manager, find out how can we best facilitate this, get transportation involved if they can do it or not, so that he can be seen in a timely fashion. Now, let's suppose because he lives so far away, he says, I can't come in for a visit. I'd like to do something. Can we just have a phone visit? And I say, I can do something better than that. Let's do a video visit. Well, I don't like the technology. I don't have a way of doing that. I will then place a consult for digital divide. What that entails is a social worker will then get in touch with the patient and determine, do they have internet access? If not, how can we get that to them? Do they have a smartphone? Or if I say I want to be able to see their vitals, can I get them a VA-issued iPad with peripherals like a blood pressure cuff, like a pulse ox? You get the idea. Those resources will then be provided to that veteran. And on top of that, the social worker can do what we have, which is a screening called ACORN, which is basically assessing circumstances and resources for needs. And what that does is it looks at their financial insecurity or food insecurity, their housing instability, and then offer them resources to make them as well as possible on a holistic level, not just for the medical care that we're providing them. Because what we've been hearing and what we know is we can do the best that we can as providers. I can give my patient the information. I can assess that do they understand what I'm telling them. I can even, through our VA now, give them those educational resources that they can get by video or by print material, and it can get auto-documented into our electronic medical record. But that post-engagement part, how am I going to ensure that they're able to implement those recommendations? Well, that's where I need to make it as easy for them as possible. How does this translate to public health? What I think is really important is that when thinking about how we do things at the VA on an individual level, How can we transform that into the public health setting? My vision would be that we have a public aligned care team or resources. Because if we don't make things easy for patients or the public to do, we can't expect changes to happen. We heard a reference in the last talk about food deserts. I can tell patients, you can reduce your chronic diseases and development of those diseases if I just help you with your lifestyle changes. But if they live in that food desert, it's not going to make it practical or easy for them to do that. Likewise, I can tell them you need physical activity minutes. You've got to get outside. If they don't feel safe, that's not going to happen. I have to find a way. So I think for communities, it's important that we have those stakeholders and those businesses to become engaged, because it takes a village. And in the VA, seeing a patient with the surrounding support staff is our village. But in the community, we too need to have that level of engagement, and we need those stakeholders and those businesses, places of worship, and community health workers to come together so that combined we have a way of treating the public and transforming health.
Terrific, and obviously an incredible role model, as you say, for translating from the VA to broader communities and public health. Love that. So I'm going to really encourage our audience members to start thinking of questions that you may have to ask of our panel. As you are developing your questions, I'm actually going to take a deeper dive. We are here talking about AI and machine learning. This is about data. And so, Erin, maybe I'll start with you, circling back. You mentioned your virtual peer coach. What sort of data are feeding your virtual peer coach from the human-human peer interactions, and how do you transform that into a 2 a.m. Virtual peer coach event, and does it continuously learn and continuously improve in its coaching abilities?
I think the answer is we're right at the beginning. So I think this is a data set that doesn't exist. So a conversation between a peer coach and a cardiac surgery patient is it's occurring at a different level. So it's not an intellectual conversation. The trust that's established between a cardiac surgery patient and a peer coach is happening at a deeper level. It's happening heart to heart in many ways. So the patient understands that the peer coach has been through it. The peer coach is not there to tell the patient their story. The peer coach is there to be present for the patient and help them develop their own capabilities. So what happens with a lot of cardiac surgery patients is it's overwhelming. The process of going into surgery is just overwhelming, and so they shut down emotionally, which is a pathway to depression. So what we're trying to do with these patients is to help them uncover their own resources, and so to ask questions about maybe it's okay to feel anxiety, maybe it's okay, maybe I can get through this, maybe I can experience this, I don't need to go into my historical patterns of emotional shutdown because of trauma. So those conversations, from what I can understand, are all new. These conversations don't exist. And so these transcripts of conversations, the conversations that people are having at a peer-to-peer level in our community, we're going to learn. We don't know what the answers are right now, but we know that the data doesn't exist anywhere else. And so we're looking at different models of AI because we don't think that the answer is going to be some kind of faster intellectual process. There's no shortage of intellectual information for a cardiac surgery patient. If you want to go online and find out everything about your procedure, everything that's going to happen, it's all there, but none of it helps. Because all you're really trying to do when you go into surgery is just let your body do the work. So you're trying to get the intellect out of it and bring calm to the body. So how does AI service that? That's a totally different question, and we're right at the beginning of asking that question.
But I think it makes sense, ingesting those transcripts, using the language models, generating, and then iterating to find the right answers or the right package of conversations to be having with each different type of patient.
Yeah, and I can tell you philosophically what we're doing is basically relying on this whole wonderful world of AI to go do a bunch of great things. So it's going to build a whole bunch of framework tools, baseline tools, things that we can use, and what we're going to have to do is going to be different. Our application of AI is going to have a unique approach. We don't want to rebuild what everybody's doing in the intellectual model of AI. We want to look at it and say, how can we support someone's generative development as they move into this process, which is an emotional mental health issue. It's not more information.
Can I flip the script for a second? Because I'm recalling a pretty traumatic moment in my training, and I think everybody in the audience at one of these meetings when I was a fellow, there was a very famous study presented where specifically nurses reached out to patients after cardiac surgery to check in on their mental health, to ask them specific questions about whether they were depressed or not. And unfortunately, among the women patients in that study, there was a higher rate of mortality. And it was felt to be because they were actually being forced to confront the fact that they were depressed. Sort of a shocking thing. So is there risk involved in letting a machine start to take over some of these interactions? And I wonder about that. I think all clinicians worry a little bit if the AI is going to be interfacing with our patient. Is there some risk involved here, and how do we mitigate that?
I think there's more than risk, there's responsibility, right? So I think the responsibility is the key. There's going to be, the AI is meant to serve the coach relationship. It's meant, there's a human in the loop. That's the technical description for it, but there's a human in the loop always. The AI is meant to augment. And so having a philosophy, for us, it starts with the philosophy of why we're doing this. And what we're doing this for is to serve patients, to help patients raise up, to have patients go through the process in a more healthy way, to reduce anxiety and depression. That's counter to having any AI system available that's going to present any risk to a patient. That would go counter to our core philosophical beliefs.
And that's why the human element's so important to drive the AI in the appropriate direction. Love that. Cheryl, maybe I'll ask you a similar question. Tell us a little bit about your data inputs. Are you doing full 6-minute walk tests on everybody, or is it a 3-meter gait speed assessment? And then how do you take the data that you derive from that and drive through AI to better health and wellness?
Yeah, great question. Well, thank you so much. Yes, many standards that we use as licensed clinicians to evaluate walking speed. 6-minute walk test is more an indication of an individual's endurance. So it's a very valuable test. We love it for the cardiopulmonary population. But what we find is a better test is a 10-meter walk test. It is the very best at measuring gait velocity or walking speed. And if I could just kind of echo Aaron, really our data is on the front side right now. We need some powerful tools and AI to actually start moving the mark on wellness and assessing walking speed, because clinicians don't have the bandwidth capacity or the standardization to assess that similarly. But I would like to talk to some of the data. First and foremost, when we look at walking speed as a predictor for future health and functional independence, as well as cardiovascular and brain health, we find that if an individual is walking greater than 1 meter per second, they're fully independent, they're able to ambulate up and down stairs, and they typically can do all of their fun and recreational activities around the house. Now, if an individual has a gait speed of less than 0.6 meters per second, then we statistically know through our research and science over many, many years and a very large database that that individual needs to be doing a fall prevention program to prevent injury. And again, we know as we're looking at this aging population over years that 1 in 4 individuals over the age of 60 are hospitalized due to a fall, a head injury, or some type of orthopedic injury. And then even more critical is this population that walks very slowly or less than 0.4 meters per second. Those are the individuals that we know will have a hospitalization in the next few years and will likely, once they're hospitalized, not be able to go home to their previous living environment. So it begs the need to have greater assessment, greater AI and technology options to assess these individuals in the community, because it's all about community health for sure. What we find is if we can improve an individual's walking speed or their physical fitness, that their longevity will be enhanced by at least 6 to 9 years in our data. Secondly, I did want to speak to a couple of really good applications and AI models that are being developed and researched now. One is being developed through researchers at MIT. And this science basically takes remote sensors that can be installed in a patient's home or apartment. And those signals bounce off of the individual's body as they walk throughout their home, okay? And then it transmits data back to a clinical science department that, and they're collecting data. And it basically is an excellent tool to monitor decline in physical status and cognitive status or risk for a cardiovascular event. So I'm so looking forward to the future as that technology continues to be developed. There are also great apps on our phone now that were not there 5 to 10 years ago. One that we commonly use in the clinic that's now being utilized more in the public is called Gait Rate. Okay, so again, we can enter, the distance that the individual is walking. Typically, it would be that 10-meter walk test, but it could be measured in feet as well for simplicity and use. And then what we find is it's just basically a timer and a measured distance. But the neat thing about this application is that there are actually some science behind and some predictive AI that links the individual's walking speed with their longevity. So in the application, it actually tells them that based on their walking speed and age, how many more quality life years they have. But yeah, I've got lots of great examples. There's not one standardized method right now of using AI and deep machine learning, but we're just on this precipice, on this beginning of the journey.
Outstanding. Thank you so much. Sabina, you mentioned obviously a sort of comprehensive care team approach to patients in the VA. And you mentioned a number of different points at which data are being collected, the ACORN assessment, for example. How do you see that all coming together to, both improve healthcare through AI in the VA, but also then as a translatable opportunity to public health?
Oh, that's a loaded question. So I think with the survey, with the ACORN survey and the feedback, it hasn't been around too long. So we're going to be seeing the data on that. But I think what is going to be very, exciting for us to see, which we're anticipating, is that as we determine with each individual and assess their social determinants of health and are able to provide them those resources, how we can actually see a change in their health and well-being. And what I'm hoping, and I think what all of us are hoping, is that we're going to see that there's going to be less hospitalizations, there's going to be better when they have their visits, those complications and the severity of those illnesses, we're going to see that change. I think what we're also looking at our VA is that because we do have home telehealth, remote patient monitoring, and we do have a platform for patient-generated health data to be uploaded into the system, this is all still kind of what we hear in our talks and presentations in the background. But I think what we're all going to be looking forward to is that change in metrics again in their overall health and decreasing hospitalizations and improving health and well-being. Our data bank is so large that we have a whole separate section, and as the research keeps on coming, we have a lot of pilot studies as well, and they come and they go. So we get some initial data on how telephone lifestyle coaching may have been really beneficial for individuals as a gap between visits, but then for reasons that are due to funding usually, then it kind of pauses, and where it's going to get reintegrated into the VA, we just don't know yet. So I don't know if I answered all of the questions, but what we learn at the VA, because we come from the national guidelines, we implement them at the VA, we can then convey those findings to the community and to community health partners.
And I think, a common thread running through all your responses is, that red flagging and that feedback loop that gets much more rapid as we let the machines kind of be part of this process is clearly going to help us with patient care, with improving community health, and ultimately identify individuals within our public health sphere who need extra resources, who need extra attention.
Right, and I think on that note, I think it's really important to establish the difference between equality and equity, because what we know is that one patient is in one situation can be very different from another one. And if we just kind of go broad and say, oh, we'll just give everybody a VA-issued iPad, that doesn't really meet the need of the individual who might need that extra support. So I think we really need to focus a lot on equity over equality. And we hear this a lot, but it really is important about meeting patients where they are. And I think that's one thing that as we have in our integrated healthcare system and implementing that, I'm hoping that we're going to see the benefits of that implementation on a large scale for our patients.
Terrific. Got a large audience out here.
I know.
Let me see if anybody would like to ask any questions. Karen? And as you ask your question, please introduce yourself. Tell us a little bit about yourself. Karen?
Mm-hmm.
Actually, we have a mic coming for you.
Karen Larmer, CardioSense, Chicago, AHA volunteer. And I work in the machine learning space with physiologic signals, but as I'm thinking about, especially what you were talking about, detecting depression post-cardiovascular surgery, it makes me think that the beauty of AI is early detection. So even if it's not physiologic, with large language models, if there was a way to screen and use large language models to detect people that may be at a higher risk for post-surgical depression, that would be a way to, as we use it in many other ways with physiology, to scale and target people who are more at risk, who have a higher propensity for that, because otherwise the effort becomes, well, we know people have post-surgical depression, then you treat the population broadly, but that's not scalable, and we know it doesn't happen as aggressively as it probably should. But I don't know if that exists. That's not really the space that I'm in, but as I think about the way that machine learning works, is the idea is you use data that's available to target what you need to target. And to me, that would be possibly a way to do this.
Aaron, any thoughts?
I think the universe of data that's out there to help us understand people that are at higher risk is wonderful. I think I think all of it will be helpful, and I think all of it represents signals that can come in and help us understand what types of intervention someone might need. Where we're coming from is what is the role of patients in supporting other patients to introduce emotional and mental health attributes to the care. So to introduce interventions that help them if they have a higher likelihood of depression and they're going to go in to have cardiac surgery. The question is, then what? Then what do you do? So what do you do for someone who's, because I think it's a full cycle thing. Like my experience with it and a lot of people's experiences, you're more likely to have depression after cardiac surgery if you were more likely to have depression anyway. So there's a lot of signals that we can use, and I think that they're all helpful, and I think that the role of peer coaching and peer community in it will expand, and it all becomes more useful the more data that we know about patients and the more we can help them and intervene.
And there is an idea, I'm just thinking about it now, we do have validated screenings for depression, right? We've got the PHQ-9. It might be really worthwhile to, and I don't know that this is done customarily before surgery, it might be worthwhile to actually implement that screening tool prior to surgery, get an idea what a patient's baseline might be, which even it may not be baseline if they got diagnosed and they're already starting to have feelings and apprehension, but then to do that assessment again afterwards so that we may have an indicator prior to surgery that this might be an individual we need to really watch closely. So I think that might be one way to start integrating that, because I think you
Which we do. So we used, so in our first study we used the PHQ-9. Now we're moving to the HADS score. One of the interesting things, so how AI solves some of these things I don't know, because some of the patients who had the rosiest PHQ-9 scores were the most at risk. So the people who tell you everything's great, you worry about a little bit, because they're coming in with stories about everything that they're going to do to shut themselves down emotionally to get through this, because that's how they've done it before. So the story comes out in the initial PHQ-9, they're like, everything's great. I'm like, everything's great? Okay. So that's, it can be, the data sometimes, you got to understand what to do with the data.
Right.
And what are their Google searches that might be actually more informative than the direct answer to the questionnaire? Right. Other questions from the audience? Got to be something. Mm-hmm. All right. Last thoughts from the panelists. We've got a couple minutes. Anything else that we didn't touch on that you'd like to make sure we impart?
I got one quick one, which is I think the whole model for AI about building this gigantic distributed brain that's going to, be smarter but disconnected from the rest of the body is a little bit worrisome. So like if you look at, we've built these fantastic neural nets that are representations of how the mind works, and it's disconnected from the rest of the body. And so the implications for health to me are pretty severe.
Fair enough. And you and I were talking before this, your first experience at our meeting, and we're geeking out on all the data and all the processes of care. Where's the patient in all this? So Webb, Pat, more patient-centered stuff, more patient-facing stuff, and let's get more patients to our meetings, and then we'll give better care. Is there a question?
Okay, all right. I'm Kathleen Willard with Tabia Health. We have a booth right over here. Sabina, this is really a question for you. When we look at our platform measures adherence to care and keeping patients on track with their treatment. And so we're having great results with like 4x adherence. But what we're finding is a lot of those social determinants of health and the data that you're collecting, it becomes a point of information, but not necessarily a point of action. And so having that information, what are you doing to be able to action the data that you're collecting for the vets? Because I know they have a pretty low adherence rate across the board, and we've seen some of that visible in the news over the EHR kind of debacle. But how are you addressing that, and how do you see AI as being able to enable more connection to the treatment plans?
So 2 parts to that. What am I doing and the AI part of it? For the part that I'm doing, this is where motivational interviewing, really assessing the patient, where they're at, and seeing if what we're even talking about is feasible, reasonable, doable for them. Because what I find is I can give them I can cheerlead them on and motivate them about if you just were able to do this, 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 and this, you would be able to decrease your pain, you would lose your weight, you would have a better glucose. But for them, that may not be realistic because of where they're at. And so I always have to pause to say, I know what I would like for the patient. First, what does the patient want? Do they even want to make those changes that I know would benefit them? Second is what can they actually do that they're willing to do? And what I find is when I ask them, well, what would you like to do? What's reasonable for you? What's doable for you? They will then start to initiate on their own, well, I could do this. Fabulous, let's start there. It's a process and it's a journey. How to have AI implemented, this comes back to the human factor. I'm still in that mindset that this human element of really engaging with the patient, really understanding how to incorporate that, where in an algorithm, is there a process where AI can provide ideas or brainstorming? Maybe. That part of it is a little bit harder for me because that's taking it to a level I hadn't yet thought about. I'll have to think about it. But I think the first and most important part is I have to really, like was discussed in the previous talk, I have to connect with the patient. I have to know what's realistic. And if it's not realistic for them, it's not going to happen even with the best intention.
Yeah, I'd like to. Oh, can I ask a question?
We are out of time. Webb, can I allow one more question? Or Pat? Okay, one more question.
Okay, real quickly, Aaron, I'm going to use this if I can. I'd love to hear you just pontificate a little bit more about keeping a human in the loop. Because what you're saying, Sabina, and what I believe is it's an AI partnership with the human being that's actually managing the relationship in large part. Can be supplemented with all the other things we've talked about, but that human being really is kind of almost the judgment factor. And so keeping a human in the loop, that comment you made, would you elaborate on that a little bit more?
Sure. I think that what seems to work, what works in peer coaching and what works in community is connection. And so what I've found to be transformative for patients is a bond that they're able to establish with a peer that exists. So my experience was, I first talked to someone who had been through heart surgery when I went to rehab. And it completely opened up my world because I hadn't talked to anybody since I'd been scheduled for surgery, and I'd started to shut down and not talk about anything. And so because no one could understand, I mean, I was preparing my will. I was telling my children that I'm going to be having major heart surgery. It's difficult for other people to relate. They don't really understand what those kind of conversations are like. And so I had stopped talking to anybody. And when I got to rehab, I was surrounded by people that had just been through the same thing. And everything just opened up, and it was such a wonderful experience. So what I've seen that's been transformative with patients has been when that bond is established, they realize they're not alone. And then when they realize they're not alone, then they're open to coaching and transformation that will help them through the experience. AI is not going to do any of that. But what AI can do is augment both. So it can augment the experience for the patient, but it can also augment the experience for the coach. Because what does the coach need to do that's going to help inform them in that session? What's going to help them help that patient? There's a lot of room for AI to do that there, but it's not going to replace the core of it, which is the bond between these two people.
Maybe that's a great place to end because we're not yet obsolete, and I'm so pleased to know it. Let me start by thanking Pat Dunn and Webb Beerbrier for yet another amazing session. Thank you so much for organizing things. I want to thank all of you for joining us, and the really good news is that you have more time with these great minds and passionate advocates. So from our prior panel, if you're interested in thinking about clinical work and healthcare, we have folks here at this round table. From our current panel, our great minds and passionate advocates, they'll be sitting here at this round table. Please come up, engage, sit down, have conversations, and continue this great discussion. Thank you so much for being here.